All right, we're good to go.
And those attendee numbers are clicking up. We're already up to 10 now. Welcome for those of you who are just joining us. I'm Jackie Dorst. I'll be your webinar presenter today. And we're just waiting in as everyone checks into the room. We will start promptly at the top of the hour. The webinar will be about 90 minutes today. And then afterwards, we have about 30 minutes to answer questions, because a lot of you, as you're reopening your dental practices after closure, you do have a lot of specific questions. So hopefully everybody's been doing so many webinars and Zoom meetings during the closure that you've become experts at this and are successfully logging on. You're able to see COVID-19, the title slide, CDC and OSHA guidance for dental practices now. And our host today is Dr. Ted Boris, and he will be doing the welcome and the announcements for the Chicago Dental Society. And then at the end of the program, Dr. Boris will be moderating the question and answer also. So I think our attendee numbers are steadily climbing. For those of you who don't know, Dr. Boris told me this morning we have over 800 attendees registered for it. So we're going to have a very large participation with that, right, Dr. Boris?
Absolutely. And it was a good sign that our members are interested and want to get things set up right for their practices as they're reopening. The state of Illinois finally allowed us to reopen this past week, and I know that a lot of people are getting prepared with all their equipment and their PPEs to do that safely.
Yes, and the state of Illinois published the health department published new guidance on Friday before the offices were supposed to open on Monday. Isn't that correct?
Correct. Yes, they didn't give you a lot of lead time to it. So.
No. Fortunately, I received a copy of the health department's guidance on that, and I was able to insert that information in the webinar. So all of the information is everything that is the latest from the last week, even from FDA and from OSHA, is included in our webinar today. So we have a lot of information to share with all of the attendees.
I know our members will appreciate getting the straight information in with an Illinois twist to it. So that's really good, Jackie. Thank you.
Yes, every state has been putting out their own specific information as both the scientific community and the medical community is learning more about the SARS-CoV virus and how it spreads, the infectivity of it, the symptoms. Even CDC has expanded their precautions or identification of the symptoms, I should say. So information, I think everybody that's attending today feels a little overwhelmed with all the information. Wouldn't you say, Dr. Boris?
I would agree with that. And I think that's a big part of the problem, is that what's correct today may not be the same story tomorrow, and there may even be some disagreement between the two, which makes it really difficult to try and get things ready.
Yes, that's been a source of angst among both the dental team members and the dentist, is the conflicting information that seems to come from CDC, from OSHA, from the dental board, and it makes us wonder in the profession, are they not talking to each other?
Right, absolutely.
So I assimilated everything, and we'll share today the best practices that we know at this time for you to safely resume seeing your patients, and to be safe for the dentist and the dental hygienist and the dental assistants as you reopen your practices.
And I think that is really the biggest question that our members have is, just to make sure that they're not going to be bringing it home and they're not going to be spreading it to other people.
Yes, yes. It's an unknown disease. The certain high number of deaths with it are scary, but the more knowledge you have, the more safe you feel and the more confident when you're practicing. So that was my goal in putting together the information for the Chicago Dental Society today, was to provide that information so that everyone could make sound professional decisions as they reopen their practices.
Well, that's great. I mean,
Yeah.
we're looking forward to it, I can tell you that.
Yes. Yes, and for everyone who's listening now, we have not officially started the webinar. It will start at the top of the hour for you. We're just waiting for all of the attendees to sign into the Zoom meeting room at this time. So Dr. Boris and I are just talking to give you a sound check to make certain that you do have sound on your computer and that you do have the video on, and you can see the title slide up, COVID-19 CDC and OSHA Guidance for Dental Practices. And Joanne, with the Chicago Dental Society, sent you out this morning in an email the handout attachment, which is copies of the slides for you to make notes on if you did a printed version, or if you can make them on the side of your digital version with it, as you again look at all of the infection prevention measures that you're implementing in your dental practice as you've resumed seeing patients this week, or if not this week, some offices, even though the health department and the dental board gave you the go-ahead, the green light, if you will, for reopening, some of you don't have enough PPE, and you said, okay, we'll wait a few more days before we start seeing routine patient care. Is that right, Dr. Boris?
Yes, I think that the lack of PPE is going to be the thing that's going to hold a lot of people back. Gowns for certainly are an issue here. Everybody I talk to is, that's the first thing they say is, do you know where we can get gowns? And that is really a problem.
And Dr. Boris, I sent you a link that was provided by one of the dental suppliers, Benco, on a webinar that was on the supply chain shortage and why there's a supply chain shortage and what for us to look for in the future. And taking that shortage into consideration, because there is a lack even of the raw material that they use to make these disposable gowns out of. And we Americans, we're very resourceful. We all, when there was a shortage of masks, how many people started making masks?
Right.
That, they were seamstresses, they were sewers, they went to the fabric store, they bought mask material, and they started sewing masks. And we had an abundance of cloth masks. Even though they provide limited protection, it preserved that N95s and those higher level masks for the first line responders with it. So maybe we can make our own gowns. Making an isolation gown is not that complicated. And we're going to look at a couple of them in the webinar today. And I think we can get all of those seamstresses out there who've been making masks, and maybe the quilters, and start making isolation gowns, because for us in dentistry, that isolation gown does not have to be fluid resistant.
Right.
The dental offices can actually, purchase their own fabric, make them colorful fabrics if they want to, and have someone locally sew it. And take a photograph of the entire team and post it on their social media and say, we're shopping locally for our PPE. We're contributing back to the local economy and getting back to work.
That's going to be an interesting thing. I'm old enough to remember the cloth surgical gowns that we wore back in the day, and then sent them off to the laundry and that. So I think that in some cases that may be what people will resort to currently.
Yes, a lot of the gown manufacturers resorted to wearing, they either went out of business a number of years ago, or they were just fabricating the jackets that snapped up the front. However, the gown with the solid front gives us a greater protection, and it is very easy to sew. So I think getting someone to sew those. I even went online to a couple of the craft stores and looked at the Simplicity and the McCall patterns, and they do have patterns for isolation gowns readily available, and the fabric does not have to be fluid resistant. Any type of fabric that, as OSHA says, prevents the normal splatters and splashes that you're exposed to from sinking through that fabric to your clothing underneath is acceptable. It provides adequate protection. So for us in dentistry, we don't have the blood that they might have
Right.
in the operating room at the hospital. So just a regular fabric, maybe a permanent press, so it comes out looking pretty out of the dryer and not like a wrinkled handy wipe, would provide them the safety and the precautions that we need, and save the office a lot of money in the long run.
Probably, yes, absolutely. Especially all those people that bought washers and dryers to put in the basement of their offices back in the day, and they've been sitting, just sitting there for the last few years.
Well, we're going to start using those again, because it's going to be both the environmentally friendly and the cost-saving way to provide that protective covering for us. Now, I'm looking for those of you who are just joining us. Dr. Boris and I are chatting to give you a sound check prior to starting the webinar at the top of the hour. I now see that we have about 229 have registered. For those of you who don't know, we have over 800 that have signed up. And you know how you are. You sign on 2 minutes before time for the webinar and you go, oh, they're going to do the introduction anyway. I've got a little bit of extra time here. But we want everybody.
They don't want to hear me talking.
Yeah, they don't want to hear our social chatter here. Yes. But again, that's just for your sound check, so that you know that your microphone's working, that you're going to be able to hear all of the information that is in the webinar. I hope everyone received a copy of the handout this morning. Joanne emailed it out. Since this is Jackie, for those of you who just have joined, I didn't email it out until late last night. It seems like nowadays I'm including all late breaking information, and I want to make certain that you have accurate information. So it was late last night before I finished inserting everything from the new Illinois Health Department guidance that was published on Friday, and a couple of other pieces of resources that I think will be helpful to you.
I'm sure that'll be a big help to everyone.
Yes. Good. Okay, everybody is entering the room now. We are about 3 minutes until start time. So we'll see a big bump up here in numbers. Now, you will, Dr. Boris, this is going to be a recorded webinar. Yes. Am I correct? Okay.
Yes, it is.
That will, if someone is not able to sign on and they don't see it, or they want to review it with the team later, how will they access that webinar?
It'll be available in 48 hours on the Chicago Dental Society YouTube site, and
okay.
You know, for free usage. The biggest difference will be that we're granting an hour and a half of CE credit for the live presentation, but not for the recording.
Okay, now will you be giving them, how will they receive that hour and a half CE, Dr. Boris?
They will receive a certificate in the mail and the email from us,
okay.
Based on their registration. So.
Okay, so they don't have to do anything on their part. That will be automatically, their continuing education certificates will be automatically emailed to them.
Right.
Afterwards. Good, good. Now, with that being on the Chicago Dental Society YouTube channel, is that an open channel that if I have a dentist in Utah call me and say, Jackie, you know, I really would like to hear a webinar, can that Utah dentist view that view our webinar also?
You're asking the wrong guy.
Oh.
Okay. I'll be lucky if I can find YouTube.
I tell you what, it's both, as we say in the South, a blessing and a curse. Yes. With all of the social media. You know, Facebook has become the new technology infection control expert. And what comes out in social media is not always accurate, although there's some helpful information. And it's a great way of sharing trustworthy information, and that's part of what we need to talk about in the webinar today, is going to your trustworthy resources for that information, such as the Chicago Dental Society or the American Dental Association, CDC, OSHA, what you can rely on to be accurate information. It doesn't always come through on YouTube or Facebook.
And I've just received a a text message from our communications director, and she informs me that it is indeed a public page. So anybody
Okay,
can
excellent.
sign on to it.
Well, I may, I've been doing a weekly video that is in the sterilization room with Jackie. And it's available on Vimeo, which is similar to YouTube. And there's been a huge response to it. And it's just a short 15, 20 minutes reviewing either what is a current topic or concern during closure and as we reopen, and then to just the basics of infection control and sterilization. So I'll add the Chicago Dental Society's webinar to my resources as I have people contacting me and looking for more information. The information has changed so quickly. It's almost like you have to have something daily that will provide you an update. And that's part of the frustration for it. Okay, well, I see that we're coming up here on the top of the hour. If you would like to do our introduction, Dr. Boris, we'll get started.
All righty. Good afternoon, everyone. On behalf of your Chicago Dental Society officers and board of directors, I welcome you to today's webinar, COVID-19, CDC, and OSHA Guidance for Dental Practices. My name is Dr. Ted Boris, and I am your Scientific Program Director at CDS. I'll be the moderator for today's program. First, a couple of housekeeping matters. CDS received a rather extensive handout from our speaker today. The link has been emailed to you this morning with a webinar reminder. This link will also accompany tomorrow's post-webinar email and the CE certificate, so you can download it for reference. You can submit questions for our speaker using the question and answer box on your screen. We will address those questions in the final half hour of this program. We will be awarding 1.5 hours of continuing education credit for this live presentation. That certificate will come to you by email automatically. You will not have to do anything to get it. The recording of this program will be available for viewing on the CDS YouTube site within 48 hours. Our speaker today is Ms. Jackie Dorst. Jackie has degrees in microbiology and dental hygiene, and over the last number of years in speaking and consulting, she has become quite the expert on instrument sterilization, infection control, and safety. Jackie provides the latest research and technical information with practical methods for clinical implementation, reviewing science, and then applying it to real-world dentistry. She has been a featured speaker at many dental meetings, is a member of OSAP, and is an authorized OSHA safety trainer. With no further ado, here is Jackie Dorst.
Thank you, Dr. Boris. And thanks to the Chicago Dental Society for this opportunity to speak with you as you reopen your practices after closure. So our seminar today is on COVID-19. What is the CDC and OSHA guidance for dental practices? You closed your practices on or around March 16th, and we were told to isolate at home to prevent the spread of the coronavirus and to limit overwhelming the healthcare system. And patients, the American Dental Association made the announcement and shared information with patients that dental offices would only be seeing urgent and emergency patients during that time. And again, it was to limit the spread, the high peaks that could have occurred with infections. You stayed in touch with your patients through Facebook and social media and let them know, hey, we're missing you. Don't forget to brush and floss. And we wanted to let our patients know, hey, we are open for emergency appointments, but only emergency appointments. Well, isolation has worked. We've stayed at home and we have flattened the curve for the COVID-19 infections. And now that there is a decrease in the number of infections with it, and the healthcare system has managed that peak in the areas where they had extremely high numbers of infectivity, such as New York City, then we're now safely reopening America. And we're in phase 1 now of reopening America, where we're still minimizing non-essential travel, but we're going back to work. Schools are probably still closed, but as we move to phase 2, Once we get through phase 1 safely and we see a decrease in the number of infections continues, then we'll move to phase 2 and we will fully reopen America and be able to fully get back to caring for our dental patients. But now, as you reopen in Chicago this week, with the announcement from the dental board and the health department that dentistry could resume seeing patients, it's time to welcome them back. And we need to let our patients know what to expect as we reopen after closure. It's going to look a little bit different for them when they arrive at your dental office. And just as when you've gone to the grocery store or to the drugstore, things are different there for you. You may go in one door and they have you exiting out another door, and in front of the cashier, they have that sneeze guard or barrier with them. Well, let them put together these friendly type of graphics that can communicate that information to the patients. We're anxious to see your smile again. And hey, you know, our lobby is your car now. And we want you to wear a mask when you come back to our office. And when you call us, let us know you've arrived for your appointment. We'll meet you at your car or we'll meet you in the hallway. Because right now, we're going to do a pre-screening with them. So when your patients come in, we're meeting them. And the very first thing that you're going to do is take their temperature. And then they'll put their mask back on after you've taken that temperature, or if you're doing the infrared on the forehead, they'll leave that mask on, and then you'll do the wellness screening. They'll sanitize their hands, and then they're ready to go back into the clinical area for their appointment. Now let's review the COVID-19. That's the disease that is caused by the SARS-CoV-2 virus. It is caused by a virus. It is an envelope virus of a very small particle size, 0.125 microns. It's important for you to know that it is an envelope virus because some of your disinfectants are effective against envelope viruses, and some of them are not effective against, say, non-envelope viruses. We got fortunate, if you want to call it that, with the SARS-CoV in that it wasn't envelope viruses, because envelope viruses are the easiest to kill out of all of the microorganisms, bacteria, fungus, and the non-envelope virus can be more difficult to disinfect with. So it is an envelope virus. Its incubation period is about 3 to 7 days. The average being around 4 to 5 days right now as we are collecting more data. And I say we, the scientists and the medical community, collecting more data, we're seeing that it's about 4 to 5 days is the average incubation period. That's the time from when you were exposed to it until you actually acquire the infection. It can be contagious for up to 14 days. Excuse me a moment. Sorry. Doesn't that happen just as you start talking and the throat gets dry? So it can be contagious for up to 14 days. Transmission is by aerosols, fluids, and respiratory. The infectivity is extremely high. And immunity, well, we don't have any. Right now, even though a patient may have had a COVID infection and it was a mild infection and they produced antibodies after the infection, the medical community doesn't know whether those antibodies are going to survive and provide them with acquired immunity. There isn't a vaccine to prevent the disease. And right now, we don't have identified medicines to treat or cure the disease. There are a number of them that are being investigated. Many antiviral type medicines are being looked at to see, are they effective against this SARS-CoV virus? But right now, no specific treatment for it. The symptoms of a COVID-19 virus have been, of a COVID-19 infection, have been expanded. Initially, CDC said it was fever, that dry cough, and a shortness of breath. Now that's an extreme shortness of breath, that they're gasping to catch their breath. Then they've added in chills and repeated shaking with chills. If any of you have had a really severe case of influenza, remember how you had really bad chills with it? It was like you couldn't get warm. Muscle pain, headaches, sore throat. And this is a real unique symptom that is an identifier of a COVID-19 infection, a new loss of taste or smell. with it. So the putting all of these symptoms on your wellness screening is important for you to ask patients both prior to scheduling their appointment and as they arrive in your office. With a COVID-19 infection, 80% of the people who acquire an infection, it will be very mild. They can't tell the difference between whether they have a cold, influenza, or COVID-19 infection. And some of them are even asymptomatic. Asymptomatic patients, they may feel a little lethargic, but they don't realize that they do have the infection. And one of the things with these mild infections is the patient may not even exhibit that fever, yet even 2 or 3 days before they exhibit symptoms, they can be shedding virus. So they could potentially be infectious with it. 15% of the patients who acquire an infection will have a significant respiratory illness. They may require oxygen to recover from it. And then 5% will be critically ill. They might be in the ICU at the hospital. Intubation might be required. They may have severe respiratory, have to be on a respirator with it. So that 15 and 20%, those 20% of patients, that was the concern in early March of those patients could overwhelm the hospitals, overwhelm healthcare. And now that we're seeing the lower infectivity, the hospitals have been able to manage the number of infections, it's time to reopen America and for you to resume seeing patients. Remember that this disease is transmitted in heavy, wet aerosol droplets. The virus likes to live in the lungs. Virus cannot live by themselves. Unlike bacteria or fungus that could survive on a surface, and bacteria and fungus can reproduce on their own, viruses cannot. They have to use the mechanism of a living cell, a virus does, to replicate. So the coronavirus or the SARS-CoV virus likes to use the cells that line the lungs and the airway system, and it invades those cells and uses those cells to replicate. So when a patient coughs or sneezes and expires those aerosols out of their mouth, the heavy wet droplets contain a multitude of the SARS-CoV viruses. But yet those droplets are heavy and wet, and they fall to the floor, they fall out of the air onto surfaces, fomites, and that's where you run the risk of transmitting the disease. If someone is within, say, 3 feet or 6 inches, like we are when we're treating patients, and you respire one of those aerosol droplets, it gets into your oropharynx area, goes into the lungs, then you can acquire an infection. As the droplets travel further, they lose moisture. And when they lose moisture, they become small, floaty, what is referred to as droplet nuclei. Well, the scientists have identified that, yes, there are these small, floaty droplet nuclei of the SARS-CoV virus, but it has not been determined and established that they could transmit the infection. Yes, the heavy wet droplets can transmit the infection, and that's why we've been social distancing 6 feet out of the zone of any of those droplet aerosols with it. So this is an unknown at this time. Now look at the bottom of your screen. You can see there are other diseases that can be transmitted by droplets and by the small floaty nuclei. Measles, influenza, rhinovirus, that's what causes a common cold, or MERS, Mideast Respiratory Syndrome, a coronavirus with it in the same family. So we really, there's a lot to learn about this virus, but we know that it's the heavy, wet droplets that transmit the disease. The unknown is, as they lose that wetness and get further away, are they a risk? And this, with data and further research, will determine the precautions that we need to take. If it's determined that it can be transmitted by those small floaty droplet nuclei, then it will be an airborne transmission. Right now, it looks like it's going to be a heavy wet droplet transmission. So normally historically, since the early 1990s and the HIV pandemic, we've taken standard precautions to prevent the transmission of diseases that can be transmitted in blood and saliva. And so we've worn a surgical mask, we've worn eye protection and a protective covering as well as gloves. And now contact precautions. Look at the bottom of the screen, if you will, where I've put the pictogram from CDC on transmission-based precautions. If you were working in a hospital, the red sign might be on a patient's door that has a contact precaution disease such as MRSA or C. diff. And with that, the patient would be the employees coming in, the CNAs and the nurses would wear gloves and a gown. Now, if we go to a droplet precautions, then it would be the green sign, diseases that are transmitted in droplets. So anyone entering that patient's room would be advised to wear a surgical mask. However, if it's airborne precautions, then the PPE goes up the scale for protection, and we would see this blue sign on the outside of the patient's door that an N95 respirator provides protection against those airborne diseases. So airborne precautions. So this might be, again, signage that you would see in a hospital for an airborne disease patient. And that patient might be infected with measles, tuberculosis, varicella. So they would be in a private room. That private room would have negative air pressure, meaning that none of the air goes out into the hallway as caregivers will enter and exit. The room would have 6 to 12 air exchanges per hour. You'd wear a mask, and if it's tuberculosis, you'd wear an N95 respirator mask. So do you see how precautions are identified by the disease that the patient has and how that disease is transmitted? Standard precautions protects against the bloodborne pathogens, hepatitis B, hepatitis C, HIV, aspergillosis. Contact precautions protects against like C. diff, rotavirus, E. coli, herpes. Then we go up to what airborne type precautions. So droplet precautions would include pertussis, whooping cough, Neisseria meningitis, rubella, mumps. And then we look at the diseases requiring airborne precautions, and that could be measles, herpes zoster, tuberculosis, SARS, and avian influenza. So those diseases would require the airborne precautions. Now, as we've built new dental offices and remodeled dental offices in the last 40 years, we've opened them up and made them more user-friendly. We took away the doors. Now we can't close a room because of those open operatories. And that has become a problem with the aerosol droplets or the airborne potential precautions that we need to take. I think in the future that we will go back to enclosed rooms to confine the aerosols that we create during dental treatment. But at this time, we need to find methods to confine and contain those aerosols so that you can safely resume seeing patients for routine appointments, for your hygiene appointments. So this might be what we look at in the future. Yes, you might have one chair that is in an open area that you do non-aerosol generating procedures, say that you take x-rays in or do an intraoral scan. And then we have more rooms, operatories with doors on them again, so that we can confine those aerosols, that we can use maybe even negative pressure or use more air exchanges per hour in that room. What both CDC and OSHA are identifying for the PPE and the precautions that you need to take are determined by the procedures you're doing. Is it an AGP, an aerosol generating procedure, or are you doing a non-aerosol generating procedure? Obviously, with the aerosol generating procedures, then you're going to need greater protection to protect you from the aerosols that can be expelled during patient care. So handpieces, high-speed handpieces, oh yes. With the water that goes through that handpiece expels, that generates a number of aerosols. And hygienists, where they're using ultrasonic scaling or air polishers with it, then that generates a large volume of aerosols. So we're going to look at some methods of containing, confining, removing those aerosols that will provide you protection. So this would be the normal PPE for a dental assistant when she's doing radiographs, a non-aerosol generating procedure, obviously. She'd wear a normal procedure mask, have her clinic jacket on, and gloves with it. For aerosol generating procedures, it might even be just using the air water syringe. And when you push both buttons in combo to generate all of that air and flush away the debris around the tooth surface, yeah, your splatters and splashes. So at that point, you're going to put the appropriate PPE on to protect yourself with a gown, an isolation gown, an N95 respirator mask, and a full face shield. Those procedures would be the aerosol generating procedures whenever you pick up a high-speed handpiece, using a slow speed with some of the rotary devices that we use, maybe even the air water syringe, ultrasonic scaler, lasers, a prophy jet, air polishers, and even the good old traditional rubber cup. If we're doing polishing with a rubber cup, it's going to create a lot of splatters and splashes. As a hygienist, I know I've gone home many days and seen that green Nupro mint flavored prophy paste in my blonde hair at the end of the day. And one of the first things that I always did returning home was to go and take a shower afterwards and wash my hair after a day of dental hygiene because of all the splatters and splashes. So what we may look at in dentistry to confine these aerosols is having an extra oral suction unit. You see one that I've put on the screen now. I call it the elephant trunk because it looks like a long elephant nose with a suction unit on the end of it. Now, putting these into your existing operatory is a challenge because you can see this is a rather large box-like unit. It looks like a shop vac almost, and it's going to be a little bit noisy. Just you can't move air without creating noise with it. So you're going to hear that high volume air suction that goes through it also. We're looking at a number of different units to determine which ones are effective and which ones might even just be removing the air from this unit, from around where we're treating the patient. But where does it go to once it's inside of the unit? Can we connect the unit to evacuate to the outside? Or does it treat through HEPA filters and maybe UV radiation to kill any potential microorganisms that it's removed from the oral treatment area? There are a number of devices that are available on the market, such as the Isolite suction. This was suction that provided you with great illumination to be able to see what you're doing, and at the same time, it's removing the aerosols. So maybe a combination of different techniques will allow us, as we look at aerosol removal in our operatories, to return to standard precaution PPE. So what do we need to look at and consider as you adapt your office to mitigate the aerosols? First of all, how big is your space? Are you able to enclose that operatory so that you maybe have a 12 by 12 by 12 foot type ceiling, and you're in a smaller space and less cubic feet of air? Or is it a big open bay area, such as in pediatric dental offices or orthodontic offices, that you have a lot of airspace? You have to know how much airspace you're going to be treating and removing aerosols from before you can purchase the correct equipment. Next is to look at your heating and air conditioning system in the building. How well does it filter the air? How many air exchanges does it provide per hour? So the standard for a healthcare facility, for an ambulatory surgery facility, patient treatment rooms in the hospital, would be 6 air changes per hour. That would be the minimum to just remove normal breathing microorganisms that are in the air. Ideal would be to have 12 air changes per hour. In the operating room, they actually have 15 air changes per hour. And what that means is that every hour, all of the air is removed from that room 12 times. So it reduces the amount of time that is required for the room not to be, that we can turn over with patients, let's say, for us not to occupy that room if we had highly infectious aerosols in that room. So I think you get the perspective of, if we can increase the number of air changes per hour, then it's going to remove any aerosols that we've generated. And as you can see on the diagram that I put on the screen, we need to look at where is the air intake with our heating and air conditioning systems, and then where does the process that it goes through as it's filtered, and then where does it return? Ideally, we'd love to have these air intakes close to where we're generating aerosols, and then it would go through a filtration, maybe a HEPA filter and a UVGI, light irradiation in it before it's returned. And then ideally, you want to have that HEPA filter that's going to filter down to the 0.3 micron size. And I've referred to the ultraviolet, UVGI, ultraviolet germicidal irradiation. The effective range for ultraviolet irradiation is 254 nanometers. You may see ultraviolet irradiation units that are sold to disinfect your toothbrush, your phone, all of your pocket items and everything sold on Amazon. Very often, those cannot be effective against the volume of aerosols that we would generate in our operatory, or they couldn't be sold to the public, because UVGI irradiation, if it's strong enough to kill the living cells that are bacteria, virus, and fungus, it's going to affect the living cells on your body, your skin, and especially the eyes. The eyes are very sensitive to germicidal irradiation on it. So that's why in a hospital, you will see that if they're going to use this to irradiate a room to provide adjunct disinfection, they will close the door and the entire time that robot type unit is circulating through the room, so that no one is exposed to the irradiation with it. And then it has the limitation. If there's a shadowed area, the light doesn't get on it. And so anything hiding underneath in that shadow is not affected by the germicidal irradiation. Ideally, the humidity in your air should be between 40 and 60%. That's the ideal to control the microorganisms in your offices. And then CDC went further and said, well, maybe you can put up barriers between the patient treatment areas and the rest of the dental office or the medical facility to prevent any aerosols from traveling into, say, the reception room or up to the front desk area, or room dividers, again, to reduce the flow of aerosols throughout the entire dental office. And if you have a room that you can make a private room, maybe it's been a treatment coordinator room, or it's been a separate room that you could put a dental unit in, then that's what we may look to in the future as we remodel our offices. When you're seeking advice on your HVAC system and how much filtration, air exchanges per hour, you need the advice of an ASHRAE engineer. That's the professional organization for heating and air conditioning people, that they look at air flows and they understand what is required by a healthcare facility to remove the microorganisms and provide clean, sanitized air. This is an example of what a negative air pressure room is. You can see that it's a hospital room example. So there's the patient bed. We would be looking at the patient treatment chair. But all of the air, because it's pulled out of the facility, when you open the door, it's sucked into the room. It doesn't go out into the hallway. It doesn't enter the rest of the building. So it is confined to that one room. And hospitals have known this. Again, if they have a patient in that bed that has measles or tuberculosis, airborne transmitted diseases, then they've had to look at how are we going to purify the air in this area. And there are some portable units. Many of the hospitals, though, they have designed air isolation rooms that have an exhaust system that it removes the air right here at the head of the bed where the patient is breathing in and out. But here you can see this is a Quattro HEPA air filter purification unit that is a hospital type, and it takes in the contaminated air at the bottom. It treats it as it filters it out. Most units will have even a UVGI irradiation, and it requires time to be exposed to UVGI to kill the germs. If the air is pulled through too quickly, it doesn't get enough time to expose and kill all of those microorganisms. And then clean air is exhausted from the top. Ideally, with a unit like this, it would be great to exhaust any air from it outside the room. This unit would treat, if you look at the small print at the bottom, up to 1,766 square feet. So that could accommodate the average treatment size operatory. But again, you would need one of these for almost each operatory if you're looking at that type of aerosol control. This is an example of extraoral suction, and again, it's the elephant trunk that comes down with the capture device to capture any aerosols coming out of the patient's mouth. And look how much room this takes up. So again, it's going to be logistics, just positioning it in the operatory, and then I can see patients who would become anxious or almost claustrophobic with having something like this in front of them, and it's making noise. It's going and sucking up the air. That's going to be, when you have the anxious patient or even a small child, it could cause apprehension for them. Look at your high volume suction unit. There are even attachments that you could put over that look like this funnel, and it would serve as a capture device for aerosols also. We saw the Isolite. Here's another exuction that for, like, orthodontists use this a lot, where they need to be able to have access to all of the facial surfaces of the teeth. And this exuction, should they be removing the adhesives after doing a debond, then it would capture the aerosols as they come out of the patient's mouth, and you're doing the cheek retraction in it. One of the devices that I've enjoyed both professionally and as the patient is the Relief Dental. My hygienist has used this for the last couple of years during my prophylaxis appointments. It's a very soft, pliable leaf. It's comfortable to the patient, and you can see the tip has holes in it, and there are holes all the way around the edge that reduce the aerosols as the hygienist or the dentist is using it. It attaches to the HVE, and look at this nice U-shape adapter. The U-shape adapter allows you to put it next to the buccal surface in the patient's cheek, and it will hang there without requiring an additional assistant or another person in the treatment area. So I was able to insert a little video in here to give you a demonstration. Now, as you can see, he has an orange tube in his right hand that is going to generate an aerosol smoke for demonstration purposes, and then the Relief is in his right hand. So let's watch as they use a Relief.
Removes all that smoke, all that aerosols out of the air. And we're going to continue to do that on and off, so you can get the idea of how well Relief works.
Relief off, and look at the aerosols. On, immediate removal. Now, using a saliva ejector, that's less effective, because even when it's on, you can still see aerosols coming out of the patient's mouth. There is some reduction, but not complete evacuation of the aerosols. So I think this is a great visual demonstration for you to see how effective these intraoral evacuations, aerosol reduction, can be if we have a device that allows us to use the HVE, the high volume evacuation. Now, as you return to your offices, please check your vacuum pump and verify that the filters are clean, that you've cleaned all of your lines, that you're getting the maximum suction from your unit, so that these devices will be the most effective. Now, the American Dental Association published a return to work interim guidance toolkit. It is excellent. It provides you the resources that you need to safely reopen your practice. The topics discussed are: how do you announce to your patients the welcome back. Hopefully you've all sent out those letters, you've posted it on Facebook, you've sent them emails, and on your phone calls, you're reminding. It talks about the pre-screening appointment. What information do you want from the patient? What do you want to communicate before the appointment? When you do that in-office patient registration, or the patient actually arrives, how to set up your reception room, chairside checklist, staff protection. What do you need to provide for staff protection? A shopping list for supplies. Well, we're all shopping for supplies now. And then the appendix has the letters, the forms, the logs for keeping temperatures of both patients and of the staff as they come in. So let's review. We're going to wrap around both the CDC recommendations, and CDC has a very helpful dental settings during coronavirus page. So if you go to CDC coronavirus dental page, put it up in the search box there, it's going to take you right to this page with all of the information that you need to know for infection prevention during the coronavirus pandemic. Now, OSHA has also published additional guidance in above the normal bloodborne pathogen standard type of guidance, and this is preparing for COVID-19, and it's precautions, safety precautions for high-risk professions where you are exposed to a greater risk of acquiring infection. And when they listed the pyramid of infection, the blue area, low risk, might be someone who works in an individual office in a room all by themselves, never comes in contact with the public. Medium risk could be the cashier at your grocery store. She's, she or he are at risk of being talking to the public. They could acquire an infection. High risk is going to be nurses that are working in maybe family health care centers, and they're seeing a lot of number of patients. They're not intubating those patients or in close contact with them. And then dentistry, because of the aerosols we create, we were put in that very high risk. So in the guidance from OSHA, they talked about having a respiratory protection plan, know what you're going to do to prevent high-risk employees, dental hygienists, dental assistants, the dentist, from acquiring that infection. What PPE do you need to be wearing, and how can you safely wear that PPE? Then further, last week, OSHA published the interim guidance for dentistry in there, and again identified non-aerosol protection versus aerosol generating protection that's needed. So when you're doing aerosol generating protection for OSHA guidance, they stated continue to practice standard precautions, add in contact precautions, and airborne precautions if you're generating aerosols, or if you have an identified patient that has a COVID-19 infection or possibly could. Now, with OSHA, I think they didn't fully consider where they put in well patients and non-well patients, because for us in dentistry, we have to go by universal and standard precautions, that we are going to have to consider all patients as potentially having a COVID-19 infection. Because remember when we talked about the disease at the very beginning of our webinar, patients can be asymptomatic and be in the 2 days before they show those symptoms and still be shedding virus. So it's really our PPE and our precautions are determined by whether the patient, whether we're doing non-aerosol generating procedures or aerosol generating procedures. OSHA further went on, what is the PPE during a COVID-19 pandemic? And this is where they identified well patients and patients suspected. However, if you look closely at the graphics on this, at the box, what's contained for non-aerosol generating procedures. Now, for an orthodontist, that may be just changing an arch wire, or for a dental assistant, taking intraoral radiographs with it, or doing an intraoral scan. None of those would be aerosol generating procedures. So you're going to wear your normal scrubs with a isolation gown, gloves, and then eye protection, your safety glasses or a full face shield, and a face mask, as you've always done. However, if we start generating aerosols, then the recommendation is to wear gloves, gown, eye protection, and that's where OSHA says go to an N95 filtering respirator. And notice as we go across the diagram, getting to the far right side, even if the patient is suspected or confirmed COVID-19, the PPE is exactly the same. And in the notation at the bottom, then it talked about adding in, contact precautions and then airborne precautions. This is a diagram, the reverse pyramid of the OSHA hierarchy of hazard control. And I think it's important for us to understand this as you look at mitigating aerosols in your office. At the very top of the pyramid, the most effective, the safest measure is to eliminate or physically remove the hazard. You're doing that when you're screening patients prior to their appointment. If the patient says, oh yeah, I have a fever of 101, then you're going to say, well, let's wait and schedule your appointment 14 days out. So you're screening them for signs, symptoms, and reappointing them until they're non-infectious out of that period of time. So that's part of physically removing the hazard. Also consider if we can do aerosol mitigation and we can use one of those extraoral suctions or intraoral suctions, that's part of eliminating the hazard, which would provide the greatest safety. Substitution, well, right now, as we reopen our offices, until we can mitigate that hazard with equipment, we're replacing the hazard, and unfortunately for hygienists, rather than doing ultrasonic scaling, we're looking at hand scaling again to reduce those aerosols. Engineering controls isolate the people from the hazard. Well, that could be using these extraoral suctions, or even looking at your heating and air conditioning system and installing that HEPA filter in it and seeing how many air changes per hour do you have. Administrative controls change the way people work. And then the least effective at the very bottom of the pyramid is PPE. And the reason it's least effective is the equipment may not be as effective as we hoped or thought that it would be, such as these international KN95 respirators, or we may not wear it correctly. If we don't get a complete seal around it or understand the correct technique for donning and doffing, then the PPE could fail to provide the protection that it should. So right now, this is the interim. Now, and please remember, it's interim guidance that was published by the Illinois Health Department with it on Friday for routine oral and dental care. And it's pretty much what we are going to look at as we go through the ADA guidance on it. One of my concerns, though, was on page 2 of the 3-page document. It said oral health facilities should do these following steps to mitigate aerosolized SARS-CoV-2. Use techniques to reduce the aerosolization. Well, that could be like the relief that we just showed for intraoral evacuation. Use portable operated HEPA filters of the appropriate size, placement, and maintenance. Well, we've already talked about that. How large is the space? If you're going to use an extraoral suction or an air purification unit, if it only filters 400 cubic feet, then that's a drop of water in the lake, as they say, to what you need to be doing. So you've got to look at the size of the space with you. And then the third was use a properly designed and maintained ultraviolet system. Well, many of you haven't had the chance to review these systems or look at what's going to be effective in your office. So when the health department did looked at it, and they had so many comments coming from the Chicago Dental Society and individual dentists and all, they said, no, this is our guidance for interim. It is not a hard and fast rule. These are what we're recommending that you prepare for your office and look to in the future to provide safe patient care. So we're doing a lot of things to mitigate aerosols, to reduce our reliance on PPE. So as we're reopening, we need to plan, prepare, and perform. So the first thing is ordering supplies. And I've heard so many of you say, we can't get those N95 respirators. Then we're going to have to look at what is your alternatives for providing safe patient care, or we can't get isolation gowns. But yet you have patients who need your care. They may have a broken tooth, an abscessed tooth, advanced periodontal patients that really need their quarterly prophylaxis appointment, that it's running not only periodontal disease risk, but total body health. And we've educated our patients on how good oral health contributes to their total health. We don't want to back up with that total patient care. So we're also going to look at how do we restart equipment that's been idle for 6 to 12 weeks before you get started. So your vacuum pump, your compressor, they may have been shut down during this time. So you need the manufacturer's instructions for use, the MIFUs, M-I-F-U, for how do you restart all the equipment. Your autoclave, your sterilizer, you're going to have to clean it. And then you're going to have to see, does the seal or the gasket, sometimes those rubber gaskets dry out in between. You may get a leakage around it. So you need to start up, refill it, clean it, put clean, fresh distilled water in it, and then run a cycle and do a spore test on it. If it's been shut down for an extended period of time, then the CDC's current recommendation is that you run 3 spore tests and have those results back-to-back spore tests, to make sure that there wasn't an error or an oversight in it before you implement use again. You got to fill your ultrasonic instrument cleaner or your instrument washer, get them all prepared, ready for use again, and then test. You all know how you test an ultrasonic instrument cleaner, that you do the aluminum foil. You hold aluminum foil in there for 20 to 30 seconds and then pull it out and look at it, and it should be uniformly pimpled or dimpled or have holes in it. If it comes out shiny, your ultrasonic's making noise, but it isn't sonicating. It is not imploding the bubbles and cleaning the instruments. And then your water bottles that are at your chairside unit, your dental unit water lines, you're gonna have to shock those water lines. Hopefully you shut them down correctly when you closed your office. You may have left one chair with water in it so that the doctor could come in and treat those emergency and urgent patients. So now you've got to shock all the water lines, then you'll add the treatment, either the treatment straws or the tablets or the drops, whichever product you use, and then you must test, again, to validate that you are in that safe zone of under 500 colony-forming units per milliliter of heterotrophic bacteria. And then train employees that wearing an N95 respirator is very different from wearing a surgical mask. It requires a fit test, and to see, every time you put it on, you should do a seal test around it. And we're going to talk about that as we go through our webinar today. So how do you safely put on and remove the additional personal protective equipment? And then you've got to create an employee and a patient schedule that respects social distance, and that we are not having multiple patients sit side by side, say in an open bay, or several patients sitting in the reception room. So you're going to have an extended schedule, that schedule that allows for patient flow and for employees that as they go through their day, they can safely provide care. Now, I'm going to caution you, if you have not worn an N95 respirator and an isolation gown before with a full face shield, this is very stressful. You are going to be so hot, and you're anxious to begin with because you're going, oh, did we remember to do this? Did we remember? Oh, you know, what? Oh, well, what about this procedure? We hadn't thought about doing this. My recommendation is that you practice, first of all, and then you allow a break, say after 2 hours of seeing patients, that you have a hydration break, because where you're going to be perspiring and this equipment is uncomfortable, and you need to catch your breath, cool down, and hydrate. Have a bottle of water with it before you resume seeing patients. Or maybe even, I would recommend that you have a floating assistant. And a floating assistant is one that brings the items to the doctor and the assistant that they might not have in the operatory, and that escorts patients in and out of the operatory, and they don't have to be in that full PPE. So it would prevent the assistant having to remove her gown and gloves to go about in other areas of the office. And the same thing for the hygienist, that floating assistant can come in and escort the patients in or out of the operatory and retrieve items, extra items that they might need. Say the hygienist sits down and she has a routine adult prophy cassette, And she goes, oh, I need my periodontal setup for this patient. So the floating assistant could remove that cassette and bring in a periodontal setup with the periodontal scalers in it. And then a second person that would do sterilization and disinfection. So that sterilization dedicated person would be removing all of the contaminated instruments, the barriers, taking those instruments into the sterilization room, then properly disinfecting the operatory and setting it up for the next scheduled patient procedure in that operatory. It may be that the team members rotate out during the day to give them a break from wearing all of the extra airborne PPE precautions with it. So create that schedule that all team members know their assignment, but that you are also allowing for that break time to recover and freshen up, rehydrate, and practice, practice, practice. The more comfortable you are with the new procedures, with the airborne precautions, the more confident you will be, and your patients will perceive that. You can welcome them back with the joy of seeing their smiles again, even though they may not see your actual smile behind your mask, and let them know how happy you are to be back caring for patients. CDC has provided a PPE burn rate calculator to help you to determine how much PPE do you need. So you could put it into this Excel spreadsheet, and you want to have enough PPE for your patient schedule for an average of 2 weeks. Remember, supply delivery times are going to be much longer than they have been in the past. In the past, you might be able to call Patterson or Shine or Benco and say, hey, I need a couple of boxes of masks, and they'd have them to you the next day. Now, it may be a week or 2 weeks, and the cost has greatly increased. I talked to an office yesterday that they told me before closure, they were paying $20 a box for a particular level 3 mask. They received a shipment yesterday, and it was $80 a box. I have never heard of these outrageous costs. So we want to look at preserving PPE as much as possible in between as we move from one patient to the next with patient care. For the MIFUs, for the manufacturer's instructions for use, I use this Dental Ease example. Many of you may have Dental Ease chairs, but they also included in their reopening instructions that if you have a vacuum pump that is a Ramvac Bulldog or a Bison, you've got a hyperlink here. You just click on that and it'll take you immediately to what you need to do about the oil and the filter in it. Because as they said, if it sits still for an extended time, the oil could settle and you could have some clanging or banging as it reopens and maybe not even functioning properly. And then they also gave you hyperlinks for how to properly disinfect the chair and the unit and where to look for O-rings, what to do for dental unit waterline maintenance, your syringe reprocessing and maintenance on it. So a very thorough, comprehensive directions from Dental Ease on reopening the operatory with their equipment. Your team may need new training. Everybody may want to refresh themselves on basic infection control. CDC has this 10 modules of training available on the CDC website at no charge. So you could go through that at any time just to refresh. What are we supposed to be doing? OSAP has an excellent workbook on the CDC guidelines and OSHA. It's a training book, very written easily to understand. It has pictures on how to do the aluminum foil test for your ultrasonic. So I think this is a great reference book for the dental team to have on infection control and safety in your office. OSAP's an organization that I've belonged to for over 30 years. It's where I go to be the best consultant and speaker that I can be on infection prevention. You can become a member at osap.org. It closely aligns with the American Dental Association, with DAMBY, with AGD. When you become a member, you have access to the frequently asked questions. It's a great bulletin board of all of the questions that you have, and then all of their toolkits that are available to help you navigate through these new safety and infection control precautions. You also need the documentation from CDC. CDC provides the minimum standards for infection prevention that are used by the Illinois Dental Board to determine, Are you protecting patient safety? Are you practicing in disinfection and sterilization to the standard of care that you prevent disease transmission in your dental office? So you should have both of these booklets. They can be downloaded digitally, or you can get a printed version free from CDC. The blue and white one is the original 2003 document with excellent science and all of the details about disinfection and sterilization. The turquoise one is the more recent 2016 publication, and as you can see, it's basic expectations for safe patient care. And in this addition to the 2003 document, CDC emphasized record keeping and testing to validate that everything that you are doing is working. And we haven't always kept records. We haven't maintained records of each sterilization cycle or maintained the records on the aluminum foil test for the ultrasonic. So the CDC provided you with a great checklist in here, and for even some example forms of how to keep those. If you haven't reviewed your infection prevention, then I highly recommend the CDC Dental App Checklist. So if you'll go to the App Store on your iPhone or your iPad, you can go to CDC Dental Check app and download it. And it will be this checklist. It's about 7 pages, and it goes through everything from hand hygiene, personal protective equipment, to properly disinfection and sterilization. And you should be able to check yes under the assessment for each topic. If you check no, then you can write out into the side what corrections that you need to make and what maybe training or products that you need to purchase. You can name your facility, put who it was completed by, the date, and as you save this, it becomes your written infection prevention plan, as is recommended by CDC, for you to validate and verify that your office is working safely. And reviewing the 7 cornerstones of sanitary precaution is hand hygiene, personal protective equipment, respiratory hygiene, sharp safety, safe injection practices, how do you sterilize instruments and devices, and then how do you clean and disinfect surfaces. So as you reopen your offices before the appointment, communicate with your patients about what the new appointment process is going to look like. Hey, we're going to take your temperature when you arrive at the office, and let them know we only want the patient to come to the office. In the past, we've welcomed the whole family, and we might have mom and grandmother come in and 2 or 3 siblings with them, but now just the patient come. And if it's a child, maybe the parent waits in the car or goes to Starbucks and has a coffee. If you're in a downtown Chicago area and you have limited parking, or they're using public transportation. We're going to do a wellness screening form to evaluate what the infection risk is. We're going to ask the patient to bring their own mask to preserve your PPE. So have them wear their own fabric mask as they come to the office. Ask the patient to brush and to floss before they arrive for their appointment, because your oral hygiene sink, if you had one, or your oral hygiene area is closed, again, to reduce cross-contamination in your office. You're going to give them a telephone number to call or text. It's a dedicated phone number that they can let you know, hey, I've arrived, I'm in your parking lot, or I'm waiting at the front door for you to come and let me in. It needs to be a dedicated phone number, not just the phone at the front desk where they're going to get a busy signal if the front desk person is on that phone with another patient. So some sort of dedicated communication number. And then you're going to take their temperature and let them know this. Again, this is all before the appointment. Hey, we're going to be taking your temperature when you arrive, and we want to get an accurate temperature. So please don't drink anything really hot or really cold about 30 minutes before you arrive. If you have patients that are traveling quite a distance, maybe it takes them an hour to get to your office, recommend that they take their temperature before they even leave for your office. If they're running a fever that day, then you don't want to see them. You're going to reappoint them if they show up at your office and they're running a fever. So that might be something that the front desk team communicates prior to the patient's appointment. And advise them to please bring a sweater or a jacket with them, even when it gets to be July and it's hot in Chicago, because your office is going to be cold. As you're wearing all of the additional PPE, you're putting on that face shield, you're going to be hot, and that thermostat is going to be set at a lower temperature. And if patients come in their summer attire wearing shorts and short sleeve t-shirts, they're going to be sitting there shivering in your refrigerated dental office. So please say, hey, you might want to bring a sweater because we're keeping that thermostat set lower in our office nowadays. So create all that information, put emoticons in it, some sort of friendly welcome, that it's not just black and white list of bullet points that they need to expect for your office. They'll read if it has pictures in it and it has color. So taking their temperature, when you take the temperature, you want the temperature to be under 100.4 degrees Fahrenheit. There are some people who normally run a little bit above 98.6. So take that into account. If they have a temperature of 99.6, it's okay. They may, for whatever reason, they may run a slightly elevated temperature. But the threshold point is 100.4. If they're above that, then you should reappoint them. As soon as you take their temperature, then you ask them to put their mask back on, and then you're going to review the wellness screen with them. And you're going to ask them, have you had any symptoms? Have you been around anyone that is infected with a COVID-19 infection? Have you traveled to an area of high infectivity of COVID? So go through all of your triage questions. Have a table right there next to your front door, or preferably in the entryway or out, maybe in the hallway if you're in an office building, where you're going to do this triage. You're going to take their temperature, go through the wellness screening, and on your table, you've got a box of gloves, disinfectant if you're using one of these type thermometers with it, alcohol hand sanitizer, for the patients, because you're going to ask them to sanitize their hands after they're there. And then notice that on the ADA kit, right at the bottom on the toolkit, it says post-procedural patient exit. Post-op instructions to the patient should be, call us if you have any COVID-19 symptoms within the next 14 days. We're really going to ask the front desk team to either send out a text message or make a care call to patients 48 hours after their visit. How'd it go? Everything, are you comfortable? Everything's okay? And no symptoms of a COVID-19 infection at this time. Phrase it as a care call. You want to ask about their dental appointment, but you also want to know, were they in that 48 to 72 hour that pre-symptom infection for a COVID-19 infection. So post-treatment, let them know, please call us if you have a fever, symptoms, or test positive for COVID-19 in the next 14 days. And then you're going to do that 48-hour care call with them. Reception room, well, you're going to separate all your chairs, put them in the social distance apart, or if you have to, put tape over them, put a sign on them, do not sit here, to keep patients 6 feet apart. Preferably, you'd like to have that chair, if you're going to put one out front to take their temperature and do the wellness screening, that is a solid surface, a plastic or a vinyl that you could wipe down with it, not an ornately upholstered chair. We had these beautiful open front desk office chair reception areas, and now we've got to put a barrier over them. So this may be the type sneeze shield that you put up with a barrier to, again, protect the front desk team as patients come up to the front desk, that you have to handle any record keeping with them, or even pay for their appointment. You may want to have a tray there that if they're going to give you a credit card, you put that credit card on the tray and you spray it or wipe it down with disinfectant before you do the scan with it. And in the reception room, we have a sign on the front door, such as this one from CDC. Notify the front desk personnel if you have any of these symptoms. Remove all of the amenities. Many of you have beautiful coffee bars, refreshment areas, magazines. I think you can safely keep water bottles there if you want to keep a water bottle for them. And of course, we've already talked about no family in the reception treatment area. And then the front desk team is going to need to be disinfecting and cleaning these public areas on an hourly or a bi-hourly basis depending on the traffic that comes through. So you're wiping down the doorknobs, all of the countertops, and keep that on a schedule so that you know that there isn't an oversight that Janet thought Mary Sue came in and cleaned up the bathroom after 3 patients had been in there, and Mary Sue thought Janet had done it. So if we keep a schedule, just like you see in many of the airport bathrooms, they want to know the environmental services has been through that bathroom to sanitize everything. So when the patient arrives, you've got that dedicated telephone number that they can call. You've asked them to wear their mask into the office. The greeter meets the patient at the door. Now we have a chair or a table in the entryway or the hallway. On the table are thermometers, tissue, alcohol-based hand rub, trash can, mask, gloves, a patient wellness screening form. Now that form can be like on an iPad that you can do it digitally, and then that can just be saved into the patient's file. You want a trash can at the front because you're going to use it for disposing of any disinfectant wipes that you've used, maybe to sanitize your thermometer with. Or you're going to, if you're using the disposable paper type thermometers, you need that trash can to throw it away. You're going to take the patient's temperature. It's going to be under 100.4. Then you would proceed with the appointment. The patient puts their mask back on after you take their temperature. Ask the wellness screening questions. Patient now sanitizes their hands with alcohol-based hand rub or washes their hands with soap and water. And then you have the option of doing a pre-procedural mouth rinse with a mouth rinse such as Aerosol. Now there is some anecdotal recommendations that hydrogen peroxide containing mouth rinses are effective against the SARS-CoV virus. It is not evidence-based research at this time, but it wouldn't hurt. So if you want to have the patient rinse with that, have them swish, try to hold it, if it's an adult, hold it in their mouth for 1 minute. You can either have them expectorate at the sink area where you normally have, say, a toothbrush area, or you could just give it to the mouthwash to them in a cup. They swish, and then they spit the excess back into the cup, and you dispose of the cup with it. Escort the patient to the treatment chair. Patient wears a mask until it's time to start the procedure and replaces the mask after the procedure ends. The dentist and the assistant are at the patient treatment chair, ready for the patient in full PPE. And then after treatment, to preserve PPE and to prevent you having to change out of gowns and masks, the greeter or that floater assistant can come and escort the patient back to the reception room. If you have dual hallways, have an exit hallway and an entry hallway, again, to prevent the meeting in the hallway even of patients, maintaining that social distance. Now, I said the dentist and the assistant are ready in full PPE, ready to treat the patient. And to preserve PPE, then it allows you for, and this is where we get into a balancing act about removing those barrier gowns at each treatment. If it was an aerosol generating procedure, then yes, the recommendation is to remove disposable barrier gowns and dispose of them, to remove cloth barrier gowns and put them in the wash to be sanitized. However, I'm going to step off of my CDC OSHA platform and say, let's evaluate that. To transmit COVID, the SARS-CoV virus, it has to get into your respiratory system. So theoretically, if the front of your gown has a few minor splatters and splashes on it, you'd have to rub your hands on it and then stick your fingers in your mouth or something to acquire the infection. So if in a clean, aseptic manner, you can remove your gloves, sanitize your hands, and you didn't have an excessive volume of aerosols. Now, the hygienist is, if she uses ultrasonic scaling and air polishing, yes, you're going to have to dispose of that gown or remove it because the volume of aerosols was much too great. However, in the other circumstances, then you could move to the next patient without removing the N95 respirator or the full face shield or the gown. But you would remove your gloves, sanitize your hands, and put on new gloves. Now, we've always had the question in these webinars that I've been doing, what about when the doctor goes to do the hygiene exam appointment with it? Well, doctors, think about this. If you're going to the treatment coordinator's room to do a consultation, or you're going in for the hygiene exam, are you really generating any aerosols then? What is the risk of cross-contamination? So maybe you don't even put on a gown at that time. You have a command hook or a coat hook outside the operatory that you could remove your gown, go in, do the exam, or go into the treatment coordinator's room, then come back and re-don that same gown for the patient care. So it's a logistics that you're going to have to determine what works for your physical facility and for your patient schedule flow. Now, with the wellness screening, here's an example of the patient's wellness screening form. It has all of the proper questions on it. Again, it can be paper or it could be digital. The patient's going to come in with their mask. We have disposable or non-contact ways of taking their temperature with it, and they're going to need to sanitize their hands. Here are the paper disposable thermometers. They are becoming available. We had a time that you couldn't even order them from Amazon, and you can see how it's a little paper strip, and when you put it in your mouth for 1 minute, pull it out, then the where the dots stopped changing color to black, it is 98.6. A traditional, just regular thermometer like you have at home, and put the plastic sleeve over it. You can buy a box of these for 100 of them for $7. That's another way of taking a patient's temperature in an aseptic manner. I have a lot of reservations about the infrared thermometers because they can error as much as 2 degrees. And that could leave you at risk. You have to be very precise with the way that you take that IR thermometer test and make certain that you understand how to properly use the device that you're using. The medical ones are much higher accuracy with them, such as the Welch Allen. However, they've been back ordered and shipping dates are looking at 2 months for those now. The employee wellness screening on here, this is again your form for employees. You'll come in with the date, what was their temperature taken. You're going to ask them the questions. Do you have any signs or symptoms of it? You'll check off no. If you keep this on a printed paper version, then please keep it inside of a folder or some way that it is, the cover of it is not revealed to everyone. Remember, it is medical information. It should be HIPAA protected, kept private with it. So you're going to take temperatures with them, and you're going to do that screening, keep the daily log for all employees, and ask about the symptoms. Now, again, it would be a good idea if employees took their temperature before they came to the office in the morning. If they're running a fever and it's above 100.4, then they shouldn't come to the office and bring the germs, whatever they have, with them. So it might be valid to ask employees, hey, take your temperature before you show up at the office. Then that way you'll know it would be safe for them to see patients that day. For staff protection, for the front desk, they're going to wear PPE, maybe a level 1 mask. We've put a sneeze guard or a barrier, that acrylic barrier that's up front. And the front desk team is going to have wipes there if they need to wipe down anything. Have disposable pens that if patients have to sign something or fill out in a form, you can say, oh, just keep the pen, so that you don't have to disinfect that. Of course, gloves and alcohol-based hand rub. For your hand hygiene, we know that every time you remove your gloves, you're going to wash your hands, sanitize, or use ABHR. First thing in the morning when you arrive, while you're doing that temperature scan, then you're going to do hand hygiene before you go to lunch, hand hygiene after lunch, hand hygiene, and before you go in home at the end of the day. Clothing, always wear a gown. It's referred to as an isolation gown. It's going to be long sleeves, have an elastic or a knitted cuff on it, and you'll pull your gloves up over that. I have always, for 20 years, worn the gowns because I felt that it provided me a higher level of protection versus wearing a clinic jacket that's snapped, buttoned, or zipped down the front, because underneath your chin, in your upper chest area, is the contamination zone when you're treating patients and generating aerosols. The scrubs that you wear to the office, now you don't wear them into the office. You wear street clothes when you come to the office, change into your scrubs. And then at the end of the day, you will change out of your scrubs. I even recommend leaving your shoes at the office. And then if you have a washer and dryer, your scrubs can be washed at the office, or you can put your scrubs in a plastic bag and take them home and wash them. Unlike the isolation gowns, your scrubs were not contaminated because now you're wearing a gown over your scrubs all day long. So you can take them home and wash them. The isolation gowns, if you're using fabric ones, then they will be washed at your office. So here's a PPE changing room at Verber Advanced Dental Institute. They change out of their street clothes when they come in the morning, and they actually have an institutional laundry facility that brings all of their clinic jackets in, leaves them hanging here. They're by size for them, and they launder them when the employees change out of their black scrubs and their clinic jackets. They all go into these soiled linen hampers, and the institutional laundry comes in and picks them up twice a week. Removes them. If any of them need to be repaired, if they become faded, they repair them. That's all part of the cost of that institutional laundry service. And Verber Advanced Dental Group has over 150 employees. It's several dental offices that practice together. So they determined that this was the best, most cost-effective way for them to manage contaminated laundry. You may have a washer and dryer in your office. If so, as you see here with Dr. Jessica Cox's office, they launder all of their scrubs and their jackets in their laundry facility here, hang them up on this nice clothing bar, and then they're able to dress in the morning when they come in, and then when they remove their contaminated attire, it goes into this holding hamper until they're ready to do the laundry with it. Right now, it's not known if the COVID-19 infection affects pregnancy. It's just unknown. But what has been stated both from CDC and OSHA is because the information is so limited, it would probably be wise to limit exposure for any pregnant team member. So if you can reassign a hygienist or a dental assistant during their pregnancy to non-aerosol generating tasks, that would be helpful during this time. However, if you're wearing complete PPE, then you are completely protected from any exposures to any microorganisms. Now, what about if you have one of your team members who actually acquires a COVID infection? What do you do after that? Well, they can return to work when they've had no fever for 3 days, 72 hours, and 7 days since first symptoms. So if they've had no fever for 72 hours and it's been at least 7 days since they first had that fever or dry cough, then it's safe for them to return to work. Or no fever, no symptoms, and 2 negative tests 24 hours apart. So that's the protocol for if you have an infected employee and for them to return to work. So either or on those. Personal protective equipment, well, standard precautions. We've always worn a gown or clinic jacket, mask, safety glasses, gloves, and utility gloves. Now we've added in a full face shield as additional protection from the aerosols, from splatters and splashes. So during this time, we'll use high volume evacuation with any procedure that generates aerosols. It's preferable to wear an N95 respirator with a full face shield. Now, the purpose of that full face shield with an N95 respirator is to preserve the exterior of the respirator and not get all of the aerosol contamination on it, because FDA and CDC during the PPE shortage crisis have given approval for extended use and reuse of N95 and KN95 respirators. So putting a full face shield over it keeps the exterior of it from getting grossly contaminated. The same thing with a level 3 mask. It can be either an N95 respirator and a full face shield. That's the ideal. However, if you do not have an N95 respirator, then use a level 3 mask and put that full face shield over it for the additional protection of splatters and splashes, and to prevent as much aerosols entering behind the shield. So it's going to provide you that additional level of protection. Now, in one of the future slides here, we're going to look closely at the particle size and the filtration of an N95 versus a level 3 mask. and then the isolation gown that provides you that protection, and gloves. So that's your proper PPE. I've seen a lot of discussion in social media about decontaminating or sanitizing N95 respirators. When you're paying anywhere from $4 to $20 for an N95 respirator, you go, oh, how can we decontaminate this so we can reuse it? There is an excellent scientific webinar that is at n95decon.org. This is a consortium, if you will, of researchers of educational institution who have investigated the different methods, irradiation, vaporized hydrogen peroxides, alcohols. And in this scientific presentation, you will learn what are the risks and what are the limitations of decontaminating N95 respirators. At this time, I've reviewed everything that's out there, and I have not found a safe, effective method for in-dental office decontamination of N95 respirators at this time. For those of you who say, well, we saw this on Amazon, it's a wand, we can wave over them. Please watch this webinar. It's 1 hour. It will provide you with the answers to your questions about why we can't. My concern is that methods of decontamination, they might be effective against the SARS-CoV virus, but it doesn't kill Staphylococcus or Streptococcus. They can't be cleaned properly. And it even says in this research presentation that if you have any face oil, sunscreens, makeup that's on the mask, it's not going to, the sanitation method is not going to work. So it is a very complex topic. I don't think we're there with systems, again, that we can use in our private practice dental office. If you're an institution, if you're a hospital, if you're a large VA medical facility, yes, then you're probably going to have that big equipment. But at this time, I don't know of a safe method. I'm, again, concerned about residual microorganisms or even toxic chemicals that could be released from the plastics that are used to make the N95 respirators, or other toxic chemicals, especially with these KN95, the internationally manufactured. N95 respirators fit closely around your face. You must do a seal test with them. Here you can see a nurse who has worn an N95 respirator for the full 8-hour shift. You cannot wear one for longer than 8 hours with it. As the filtration device fills up and you're breathing through it, it collects all of the particles, even the dust, and it becomes more and more difficult for you to breathe through because it's filtering, it's doing its job. But where you've got to get the complete seals, look at the injuries to her skin from the irritation of wearing this close-fitting, sealed N95 respirator. For those of you who have never worn one, the first day that you wear it, you're going to go, please, can I go back to wearing a surgical mask? Because this is the type of injury it can do to your body when you're wearing one. Now look at this PPE poster put out by CDC for COVID-19 and PPE. Ideally preferred is isolation gown, gloves, N95 respirator, and a face shield. Acceptable alternative PPE is a face mask with, I would say, a level 3 and a full face shield and the same isolation gown and gloves. So look at the filtration. We're gonna look at the mask and see how they filter and determine, do you need an N95 respirator? Now with your gowns or jackets, I've said several times, I changed to wearing an isolation gown many years ago because this is the splatter zone. At one of the Chicago Midwinter meetings, on the exhibit floor, this is a gown manufacturer that we did a test on. They make a fluid-resistant gown. This happens to be Denline. And we sprayed red disclosing solution in the splatter zone. Where we're working over the patient's oral cavity, all of the aerosols that are created come right out and they contaminate our upper chest area, our neck, and even up around the mask on us. So this is where we need protection. I can safely remove this gown by reaching behind my neck and unsnapping, unvelcroing, or untying the mask and fold the outside in on the together, and therefore I control the contamination on it by the way that I removed it. I never touch the front of this gown. It's also cooler because it's opened all the way down the back like a hospital gown is. It does not have to necessarily be fluid resistant. And when Dr. Boris and I were talking prior to the webinar starting, I said, you know, I really think that with this shortage of gowns, that both the disposable ones and the ones you can purchase are not available. Can we not get local seamstresses? People who sew, the people who make quilts and have been making face masks, fabric face masks, can they not start sewing these isolation gowns? And we can purchase locally and put America back to work. So I'm going to urge us to look at this as an alternative for supplying your much needed isolation gowns. The sequence for donning and doffing are that first you're going to put on your gown, then your mask, then your face shield, and your gloves. Now, then you care for the patient. Once you're ready to leave the treatment room, then you would remove your gown, remove your mask and your gloves, but leave, remove your gown, remove your gloves, sanitize your hands. Let's go backwards. Remove your gloves, sanitize your hands, then remove your gown, then remove your full face shield. You do not remove your mask or respirator until you exit the patient's room. Again, because of those contaminated aerosols. Sorry that I misspoke on the sequence with it there, but I think you get the idea. Again, from the ADA toolkit, this is understanding mask type. A surgical mask is a pleated mask. It's flat. It has the ear loops on it, and there can be gaps around the side of it. Does it come in different sizes? No. An N95 respirator will usually have normally two ties that go over, or two strings that go over the top, one over the top of the head, one over the back of the neck. And it does come in sizes. It comes in small, medium, and extra large. It is not a one size fits all. And does it fit tight? Yes, as opposed to a surgical mask that is more loose fitting. And you should do a fit test with it when you initially start using an N95 respirator if you've never used one before, and then a seal check every time you don one. And I'm going to show you a short video on the seal check. The KN95s, that's a designation for an internationally manufactured N95 type mask. And it is authorized for use in the United States under the PPE shortage. Now, I should share with you right now that the Food and Drug Administration certifies all medical equipment as well as N95 respirators and face masks in the United States. And the FDA requires testing and laboratory analysis to be provided to the FDA that any piece of equipment does what it's supposed to do safely, that it will not injure the patient and it will not injure the operator. And that's called a 510K clearance that is issued after all of that testing is submitted to the FDA. So your cure lights, your hand pieces, your ultrasonic scalers, as well as N95 mask and surgical mask have an FDA clearance. When we go to products outside the United States, we don't have that safety clearance. Yes, they're supposed to be manufactured with the same type of materials, and yes, they should provide the same protection, but it doesn't have that clearance with it. So there is a margin of risk in going to an internationally manufactured KN95. So again, CDC put together this comparison. This is the protection provided by a surgical mask. This is the protection provided by an N95 respirator. The big difference is that the surgical mask can be loose fitting. The N95 is tight fitting. That's why you do a fit test to see if it is properly fitted. The mask doesn't seal, but yes, the N95 does seal. The particle filtration is the same, really, for them. And if you're putting on your surgical mask and snugly fitting it in, then you're going to eliminate some of those gaps with it. And I'm sorry, I need to go back. So with an N95, OSHA has put together a respirator toolkit. An N95 fit test makes certain that you have the right size and that it is giving you the seal around it. And you should have a medical clearance because it's more difficult to breathe through these. Under normal times, you would have an N95 fit test before you use that mask the first time, and you would have a medical clearance that, hey, your respiratory system's strong enough. Maybe you have COPD or asthma that could aggravate it or make it difficult for you to breathe through that tight seal. And then you know how to, you've done the seal check and you've had proper instructions on it. This is what a fit test looks like. The person dons the correct size mask, seals it around their face, and then puts this hood over them, and then a bitter or a sweet solution is injected into here. They have to turn their head from side to side, up and down, even do a little bit of jogging in place to see if they can smell or taste that sweet or bitter solution. If they can, then it means that that respirator is not sealed properly or it does not fit them properly.
On your face
so let's
with the nose piece at your fingertips,
do a seal
allowing
test.
the headbands to hang freely. The nose piece should span and cover the bridge of your nose, and the respirator should cup your chin. Pull the top strap over your head, resting it high at the back of your head. Pull the bottom strap over your head and position it around your neck and below your ears. Be sure not to crisscross the straps. Make sure that your mouth and nose are covered by the respirator. If the nose piece has a metal nose piece or strip, use both hands to mold the nose strip to conform to the shape of your nose by pushing inward while moving your fingertips down along both sides of the nose piece. Next, conduct a user seal check. It's essential to follow the manufacturer's user seal check instructions because the manufacturer knows the best method for checking their respirator. Generally speaking, the manufacturer's instructions are based on covering the surface of the respirator, usually with your hands, so that air is prevented from passing through the filtering facepiece. A positive pressure seal check is performed by gently exhaling to see if the facepiece bulges slightly. For a negative pressure seal check, take a quick deep breath to see if the facepiece collapses slightly. During either test, if air leaks out between your face and the respirator's face seal, the respirator may not fit your face properly. One way that you can identify leakage is if you feel air blowing through the seal onto your face or eyes. If you feel leakage, readjust the fit of your respirator and check the seal again. If you cannot achieve a proper seal, you are not protected and should not enter.
So as you can see, that seal check is necessary each time you don an N95 to make certain that you've got that complete seal around your face. Gentlemen, if you have beards, then that prevents the N95 respirator from sealing completely around your face. So CDC's even put together a poster on acceptable beard styles with an N95 respirator, and those are the ones with the green check around them, and then styles that would interfere with the safety of the protection from an N95 respirator have the red X on them. I never knew there were so many beard styles until CDC put this graphic out. CDC, along with NIOSH, has a poster that shows you the correct way to don it. I would suggest that you download this, save it, maybe put it up in the staff lounge where you're going to be doing the temperature checks, that everyone understands how to properly don and doff. Now, this is our graphic that gives us the comparison of filtration for a procedural mask versus an N95 respirator. A level 1 mask, fluid resistance is down at 80 millimeters. Where we get the 95% bacterial and particle filtration. Moving up one level to a level 2, then bacterial and particle filtration to a 0.1 micron size are 98%. So that's pretty good filtration with it. And we've increased the fluid resistance up to 120 millimeters. Now, if we go up to a level 3 mask, the difference between the level 2 The filtration is the same, but the fluid resistance has gone up to 160. So that's basically the difference between the level 2 and 3. Do you see how they're going to give you that particle and bacterial filtration is equal in them? Now, we get 98 with a surgical mask. If you go to an N95 particulate respirator, fluid resistance is the same, but you're getting that 99.9%. So a little bit higher filtration, really 1% type of filtration with it, but the added protection comes in that seal that goes around the face. So I want you to feel confident in the protection that a level 3 or a level 2 mask would provide you during aerosol procedures. However, no matter what the quality of the mask is, if you don't wear it correctly, you compromise your protection. Look at the chin bra technique. And I've seen this many times in all of the in-office consultations and tune-ups that I do. When you've finished with a patient, you pull the mask underneath your chin and wear it there until you see the next patient, and then pull it up over your nose and mouth. Well, just think of all the splatters and aerosols this assistant had when treating that patient. Now they're on the inside of her mask, and she pulls it up and puts it right over her nose and her mouth. Or the I'm hot, I'm not going to put it up over my nose, I will put it underneath my nose technique. Again, compromising protection with it. Or we have the doctor who wears the clinic jacket, the white jacket, and leaves it unbuttoned in front. Now his shirt's totally contaminated, and he wears that home to hug his wife at the end of the day. And again, the chin bra technique. So PPE, this is why OSHA puts PPE at the bottom of that hierarchy of controls pyramid, because if we don't use PPE correctly, then we can void the protection that it can provide us. So this is what your patients are going to see when you welcome back into your office. We may have the front desk team that's wearing a level 1 mask, and she may just have scrubs on. It didn't even have to wear a gown with it. You may even have this sign in front of the desk, hey, stop 6 feet away from the front desk. We're going to do social distance here. And if you look closely at this front desk, they put this beautiful bouquet of flowers out to welcome patients. And here's the sneeze shield. Very clean installation. And then alcohol hand sanitizer along with an attractive, hey, sanitize hands here. So this team did put on their sunglasses with it so that we could see their eyes underneath their face shields with it, and did a team photo to post on their social media that, hey, it's going to be a little different when you come in, but we're so happy to see you. This is the appropriate PPE that we're going to be wearing. And you can see how much warmer it's going to be and more stress. So do schedule those frequent breaks for you, that you have a hydration break before you get overly stressed and wind up with medical complications yourself. So FDA response to the PPE shortage, they've issued the emergency use authorization that, yes, we can reuse or extended use of the mask or PPE. They even went so far, the FDA said, is that you can use filtering face respirators. Now, these are the ones that you could buy like at Grainger or Lowe's or Home Depot that are used by industry, where they have high dust areas. It's the same filtration material, it's just not fluid resistant. But if you put a face shield over it, then it gives you that protection. You want, if you have any old masks that are beyond their shelf life, CDC and OSHA are saying, go ahead and use those. And then they gave approval, FDA did say, okay, it's all right for now during this shortage crisis to use the K95s or the KN95s. To help you protect in between, maybe you wear one for 2 days, the same one. Then you need to store it in a brown paper bag. I liked the gift bags that you could store them in, hang your shield over it. You don't want to store it in plastic, because if you store it in something that is plastic that's impermeable, then the bacteria could multiply on the inside of that mask. You could put command hooks up and have those in the staff lounge or the treatment area, wherever you're going to store PPE that could be reused. And this is a decontamination that we talked about earlier where I said, please go to n95decon.org and look at the video there. This is a hospital, and you can see they have 1,000 masks that are hanging in here, and they're going to use vaporized hydrogen peroxide, a very toxic, dangerous chemical to work with. But that's the way an institution can recycle these. You have to write your name on them, on the strap of it, and then they have to get the same one back to the same person. You can't wear somebody else's because it still has potentially body fluids on the inside of it. Last week, CDC and FDA sent out a warning about counterfeit KN95 masks, and they are pervasive. I've looked on social, they're even showing up on Facebook that they're selling these, and it's hard to distinguish them. What CDC gave you was some identifying factors that you can look at. You want to know, does it have the proper label on here? Does it have a sign? Here you can see the 3M mask. It should have NIOSH on there. If NIOSH is spelled wrong or backward on it, that's a suspicion. And one of the keys to it, do you see this fine TC number that's under the N95 on it? There is a TC number that is specific for each manufacturer, and they must have, that's an FDA approval number. They must have that. FDA even found that some of the KN95s that were coming out of China, they had stolen a TC number off of another Chinese manufacturer and were putting that on their mask. So lots to be aware of to try to get effective equipment. And where they talked about if it doesn't have any markings, this is not a KN95. There are no N95 markings on it. It doesn't have any of the approval with it. And if it's an N95, it will always have 2 straps on it. Now, KN95s may have the ear loops on them, but again, this one does not have N95 or KN95 written on it. No markings anywhere. It is a fake. It is a counterfeit. Hand hygiene, we should either be using alcohol hand sanitizer or washing with soap and water every time we remove our gloves. This office even installed no-touch paper towel dispensers, and this office has a no-touch ABHR dispenser. Soap and water cleans your hands. It has a chemical called a surfactant in it that removes any debris from your hands. However, ABHRs that contain between 60 and 90% alcohol actually kill more germs than plain soap and water. But alcohol is not a cleaner. It is a desiccant. So if your hands are soiled, you must use soap and water. Be effective with your technique. You apply about a Hershey Kiss size of ABHR, rub your hands together over the top, fingers in between, around the thumb, fingers in the palm, and now you're done, so that you cover all of the surfaces. Your nails should be trimmed within 1/4 of an inch, and no artificial nails that can transmit microorganisms. For clinical contact surfaces, we have the option of using barriers or cleaning and disinfecting in between. The National Institute of Health, in their study of the coronavirus, identified that the coronavirus can survive on plastic and stainless steel for up to 3 days. So it's very important for you to clean and disinfect in between each patient. You want to know that your disinfectant is a cleaner as well as a disinfectant, that it will kill all pathogens, that it is EPA registered as a healthcare disinfectant. And I'm going to recommend to you that it is an intermediate level disinfectant. That means it kills germs even in the presence of proteinaceous debris such as blood. To identify that your disinfectant is effective against the coronavirus, EPA has put together a special emerging pathogens checklist so you can validate your disinfectant. So go to that list in disinfectants use against SARS-CoV-2 viruses, and you'll check over here. Now you will need the EPA registration number off of the container or the safety data sheet for the disinfectant you're using, because they're listed by EPA registration number and not alphabetically by name. For technology equipment, because it can be sensitive to liquids or aerosols with it, you want to have the manufacturer's instructions for use, Always use an FDA cleared barrier. And some disinfectants, if they have high alcohol content in them, they might inactivate the touchpad screen. Have the manufacturer's instructions for use, and then clean and disinfect in between each patient. Keyboards that are in the clinical area are one of the common sources of cross-contamination because we enter patients' information with our gloves on. So using a barrier over them is an option. However, that's another disposable. You might go to one of these sealed type of keyboards and washable mouse that you can actually spray or wipe down with the disinfectant wipe. And this particular one has great tactile sensitivity. And if the barrier becomes stained with it, you can actually pull it off and buy a new one. But it's good for 2, 3, 4 months, depending on the disinfectant that you use, whether it will become soiled or stained and just ugly looking. It still works. Sterilization, this is what your patients expect to see. A sterile setup of instruments on a sterile field. This CSR paper, central sterilization room paper, was sterilized along with the instrument cassette. So when the assistants opened it up, set up for the endodontic procedure, now she has barriers on all of her delivery equipment, and then her handpiece even has the barrier over the pouch barrier over the handpiece with it. Your sterilization room needs to be set up according to CDC recommendations, that it flows from dirty to clean to sterile so that you work efficiently and you do not cross-contaminate. So with this sterilization room, you can see we come in on the red area, the dirty area, dispose of all contaminated items, put the instruments into the instrument washers for cleaning. Once they're clean and dry, then we'll come over to the packaging area where the blue paper is laying on the countertop. All the pouches are on this open shelf above. Then the wrapped instruments will be sterilized. And once they're removed, they go into an enclosed cabinet for sterile storage to prevent contamination of the exterior of the package. It doesn't have to be that large of a sterilization room that you saw on the previous slide. Maybe your sterilization room's more compact, such as this one, that has an instrument washer and then a very small ultrasonic for just a few small items. This is your wrap and package area on the right side of the instrument washer. And then you can see here your dynamic air remover autoclave that is complete closed door sterilization, such as a stack clave, or a cassette type sterilization that is the Statum sterilizer with it. This is what your patients expect to see and what is going to prevent cross-contamination. Clean countertops. All items that are not used are removed from your counters. Glove boxes are even put into drawers and cabinets. And here are all of the sterile cassettes with autoclave tape on the end indicating that, yes, they have been processed, ready for safe patient care. I would say no fans in the area. Some of the old gravity type sterilizers that, you know, at the end of the cycle, the door pops open, the steam comes out, and then the residual heat inside the chamber is what's supposed to dry the cassettes, the wrap cassettes or the pouches, and often they don't dry. They come out wet. Well, CDC specifically states in the guidelines that wet packages should not be removed from the sterilizer because the pores of paper is still open and you can have wicking through of microorganisms. And in this office, they had such wet packages coming out of their sterilizer that they actually put the cassettes on a ventilation rack and had a fan blowing over them to complete drying. Well, that could recontaminate those. So even any fans that are in the clinical area in the sterilization room, it's going to blow the germs all around the area. So at this time, I would say no fans. Well, we've gone through a lot to plan your office and help you prepare for reopening if you're not already reopened. And this is the team that performs. You care from your heart for each and every one of your patients. I know you're happy to see them. You're anxious. You want to know you're doing the right thing to protect each and every patient and to protect yourselves as you reopen your Chicago dental practices. So tell them welcome back. You were missed. We are so happy to have you back to our practices, and it's going to be a safe visit. Dr. Boris, I want to thank you for inviting me to speak with the Chicago Dental Society today. And as we close, do you have any questions for us?
Well, we've got a few. Let's give you a minute to catch your breath. That was a long sermon there.
I certainly
So-
galloped through it. You thought I was at the pulpit at church, didn't you?
I certainly did. I certainly did. And we'll start out with a couple easy ones. Must the staff wear masks in the office at all times when they're there?
If the front desk team, the administrative team, if it's that area is separated from where the clinical area is, then not necessarily for the front desk team. However, depending on what the aerosol mitigation is in your office for the clinical team, I would say yes, because again, we don't know what aerosols could be present, and it could take 2 to 3 hours for those aerosols to settle out of the air after a patient treatment procedure, and especially if you don't have that extra oral suction and you haven't put in the HEPA filters in the HVAC system.
Here's a real office question. Can we assume that we should no longer eat in the office?
Ooh, good question. You know, if you have a team room, a kitchen area, a staff lounge, as we've referred to it, that you can close the door, then by all means, close the door so those aerosols don't get in and out, you know, into that area and contaminate it. And then I would probably say, yes, it would be okay to eat in that closed area. If not, if you don't have that, then definitely I'd prefer for you to find another area to eat your lunch.
Can you give some thoughts on the use of nitrous during the pandemic due to the potential for aerosol?
With nitrous, it's going to be treated, the nitrous oxide equipment is going to be treated as any other equipment will be. And hopefully you've gone to equipment in your office over the years that you have a nitrous mask that you can either take off and clean and autoclave, or that you have the disposable ones. So it's still going to be safe to use the nitrous, but you should have those good infection control protocols that prevent cross-contamination from the nitrous equipment.
Would we consider an N95 and a KN95 to be the same level of protection, assuming that the KN95 is not of the gray market type?
I have reservations about that. Now, and I'm going to have to tell you my experience in consulting clients and the KN95s that I've seen come in. I spoke with Dr. Ana Garcia last week, and she received her first shipment of KN95s. And I said, oh, have you tried them on? Because we happened to be on a Zoom training session together. She says, no. I said, oh, go get one and open it, and let's try it on while we're talking about doing the seal test and the fit test. Dr. Garcia put that mask on her face, and it went all the way back to her ears. There was not a seal. It was so big on her petite face that it just floated. There, no seal to it. And she said, I didn't even know that we could buy small, medium, and large. And many of the ones that are coming in that are K95s or KN95s, it's a one size fits all that's been shipped in. And I think that's going to prevent that complete seal around it. So in my experience, one of my concerns has been, hey, you know, that we have team members that are either going to reuse or have extended use of these KN95s and the N95s, and they're going to build up a bio burden on the inside of them, and face oils and makeup on the inside of them, where we're trying to reuse these masks that we've paid a lot of money for. As a hygienist and a microbiologist, I personally would rather wear a clean, fresh level 3 mask and a full face shield as my protection. However, that I do have to say that's an IMO as the text message, in my opinion.
All right. Is there any rule about face shields having to be tight to the face in the forehead area?
No, there is not a rule about how tight it has to be around the forehead. You want one loose that are flexible enough that it doesn't give you a headache. And there are a lot of different designs out there, and some of them will give you a headache. Like I tried for many years to use the OptiOp shield, and it was just so tight on my head that I couldn't wait to get it off at the end of the day. I like the ones that have the sponge on the front of them and that sit more comfortably on your face. And if you get a thicker sponge with it, for those of you who wear loupes, it allows the extra space for your magnification behind that shield. But obviously you wouldn't want it falling down during the middle of a procedure.
All right, being in an urban setting, a lot of patients don't drive to the office. They either walk or take public transportation. How would you propose handling that wait for their appointment?
Well, and I've thought about that. I was just in Minneapolis with a client right before the closure, and she was in right downtown Minneapolis, and there wasn't any parking in front of her office. And taking that into consideration, I would meet the patients and tell them that you're going to meet them inside the door. So they're either going to have to knock on your front door of your office, or if you're in an office building, obviously they can wait in the hallway outside the door. In the wintertime, when it's cold and snowy, you've got to get them out of the elements. In the summertime, when it's hot and humid or rainy, you still have to get them out of the elements. So find a way that your physical facility that you can manage that patient arrival at your office. And it is going to be a challenge for some downtown locations. I understand that.
And I just want you to reiterate, an isolation gown is good enough. They don't need a surgical gown.
Correct. Correct. Surgical gowns, traditionally, the difference in them is that they have maybe a second layer of fabric or a reinforced, almost a fluid resistant barrier type that's sewn into that high risk chest area. So oral surgeons, you might see them with that surgical gown. But for us in general dentistry, with the volume of splatters and splashes that we have, wearing an isolation gown, and as I've said with OSHA's quote, even one that is made out of cotton or cotton polyester provides adequate safety protection.
Is there anything that can be done to decrease the splatter and aerosol when polishing using a rubber cup? Does a bristle brush have less splatter or aerosol?
Oh, I'm sitting here shaking my head no as you read that. I am so sorry. Again, a bristle brush is greater aerosol splatters and splashes with it. And with the rubber cup, you still have, there is one manufacturer, and I forget the name of it, one of those hygienists listening can probably tell me, but it actually has a little sweep, it's almost like a little brush attached to the end of the rubber cup that does contain more of the aerosols. So it might be worth investigating one of those for doing rubber cup polishing with it. I had one hygienist say, so does that mean we have to go back to port polishers? Now, Dr. Boris, you may remember, those of us who have been in dentistry for a few years, we heard about port polishers when we were in school. I have never actually used one, but it's like a soft orange wood stick that's in an interproximal device that you pop. I think we'll find a way to manage the polishing, but right now it's one of those aerosol generating procedures. And I really feel the hygienist is going to need more aerosol mitigation even than the dentist is.
Would it be better to use a toothbrush to polish after hand scaling than a handpiece?
You know what I think is an option for that would be to give a pumice cup and a toothbrush to the patient and send them to the bathroom and say, now I'm going to give you my professional polish here. And I'm going to send you to the bathroom with this toothbrush, and all of those areas where you get stain, I want you to brush real thoroughly with it. And then if there's any stain left, I'll get my scaler in there and get rid of the rest of it. How does that sound to you, Dr. Boris?
It sounds good to me. Is the use of an electric handpiece without water still considered an AGP?
Yes. We have saliva in the patient's mouth, and when you mix that handpiece with a burr on it, even if it doesn't have water for the coolant, it's still slinging saliva around.
Now here's a confused person. They say everyone is putting some kind of UV system, along with their HVAC. How can I be certain that what they've put in is safe for me and effective against the virus?
That is an excellent question, and that's one that I asked at the very beginning of this pandemic. I can test your autoclave with a spore test and tell you, yes, it's sterilizing. I can test your ultrasonic with aluminum foil and tell you, yes, it is sonicating. Yes, the bubbles are imploding. It is cleaning your instruments. I can test your dental unit water line with a test and say, yes, your water treatment is working. It is under 500 colony forming units. I cannot test an air purifier, and I cannot test an air purification with any test that's available to a dental office now. And in line with that, I have spent the last 12 weeks investigating aerosol mitigation with several engineering firms. And in looking, and one of the engineering firms that I've been on a lot of Zoom meetings with, and they design air purification systems for the pharmaceutical industry, for the chemical facilities, and for hospitals. So they're well aware of dentistry's challenge right now with aerosols. They're working closely with a researcher at MIT on looking at these aerosols. And that's where I want you to have a reference for, is to be able to go to a healthcare engineering facility, and that they will evaluate equipment and say, yes, this air purification mobile unit will disinfect 1,740 square feet in your operatory, and even look at your physical facility. It may not be that they come to your office, but maybe you connect with them on a Zoom meeting, or you take FaceTime and go around your office and say, this is where our air intake is, and this is where our exhaust is, and this was the air exchanges we have per hour. What do we need to be doing? That's the type of advice that we need right now about aerosol mitigation, Dr. Boris, and there needs to be a lot more research put into it, and we need to bring in those engineering experts.
Does OSHA require face shields?
Okay, I'm thinking. Yes. I'm going to say yes, under the new COVID respiratory protection plan, that face shields would be required. If you either have to have goggles on or a face shield if you're wearing a N95 respirator mask or a surgical mask. Now, the reason that OSHA is saying that is, again, for eye protection. We're putting on the face shield as additional aerosol and airborne disease protection, and to preserve the PPE. If we put on a full face shield over an N95 respirator, it keeps the exterior of that N95 respirator from getting splattered and splashed, so that it preserves it for us to have extended use, or to wear it even for more than one day. If it gets all splattered and splashed with saliva and blood and pumice and everything that we're doing, then it's contaminated and really should be discarded. So the face shield helps to preserve the PPE.
On that same topic, it's been suggested that you could, if you were going to wear goggles or you're wearing your loupes and you're unable to wear a face shield, to wear a type 1 or type 2 mask over the KN95 and replace that with each patient. Is there any validity to that?
There is validity to it. If you can't wear that face shield, to put that disposable mask over it. Now, I will tell the person who asked the question, if you do that, it's going to make it very difficult for you to breathe through, because you're going to find that you're almost having to inhale real deeply to get any air through it. And because you're blocking part of the air that should be coming through the KN95 mask, then there's going to be a greater risk of actually breaking the seal around, or air coming in from the edges of the N95. And of course, then that voids your protection with it. Definitely use the most lightweight type of over mask that you could, say a level 1, or even to give that protection for the N95 respirator.
Is there a proper way to dispose of your gown and cap? Can they be placed in the regular trash bin, or are they medical waste?
No, they can be placed in the regular trash bin.
All right, we're skipping through a few of these.
Some of them are repeats. Everybody has
Yes.
the same question, which is understandable, but and we like it's good if we can get to the ones that are unique.
Are we supposed to remove an ear loop mask and a disposable gown with each patient?
I would say use your professional judgment. If you're doing intraoral radiographs or an intraoral scan, then you probably didn't have any splatters or splashes. So you could theoretically, with that, move to the next patient. However, if you've done a procedure where there's extensive splatters and splashes, then yes.
Why does everyone keep recommending asking if a person has traveled anywhere that has COVID-19? We live in an area where the pandemic is going on. We should instead ask if they've been going to the store without a mask.
Well, right now it's part of the social distancing and isolation with it. And at the beginning of this pandemic, where there were hot spots in Seattle, Washington, and in New York, then obviously people who came from that area, they should even be, if they exited that area, they should even self-quarantine themselves for 14 days before they returned. I've known quite a few people that have had to do that, especially I live in Northeast Florida, where there is a Navy and an Air Force base. So all of the military personnel who have returned from international assignments, they have to quarantine for 14 days before, because there's a higher risk when you are in an area where there's a high rate of infectivity and you just go to the grocery store, that you could have been exposed and not have signs or symptoms. So that's the theory behind it. If you have someone who has been to a high risk area, then if it's not urgent care, you might say, let's put your appointment out 14 days. And that's where the front desk team can be of help. That asking, hey, did you just return from New York City? Were you one of the nurses that was on the front line? If they immediately come back and want to come to your office, unless it's an emergency type appointment, then say, put their appointment out 14 days. So I think that's the reasoning, the rationale behind it, Dr. Boris.
If a staff member has been diagnosed or exposed, do we have to close the office for a period of time, assuming that staff member or the doctor has COVID?
It depends on the close contact with the staff members. Who was in close contact? Was it more than 30 minutes at a time with that staff member? Then yes, it might say the doctor and the assistant. If the doctor is diagnosed with COVID-19, then his or her assistant would probably need to be quarantined with them, versus the hygienist, who just sees the doctor for a couple of minutes when they're doing the exam, might not need to be quarantined. So again, you're going to have to evaluate, was that a close exposure that you were in the vicinity with the other employee for, say, more than 30 minutes at a time?
Here's a different one. Can you have a custom exoskeleton worn over a surgical mask? And how effective is the filtration compared to an N95?
I would think no on that, if I'm understanding it correctly, Dr. Boris. If that exoskeleton, say that you have the form that would go over a surgical mask, then there's still going to be a gap between where that exoskeleton compresses the surgical mask. Now, Dr. Mark Causey in Gainesville, Georgia area, he used his 3D printer to create custom exoskeletons, if you will, of an N95 respirator, and then attached the HEPA filtration with an elastomeric band around it that can be changed out. So that fabricated, 3D fabricated custom mask can be washed, sanitized, disinfected, and then the filtration changed on it for each patient. It was quite an innovation, and during the closure, he fabricated a lot of them for the first responders in his area, the EMTs, the firemen, the hospital workers, as part of his give back to the community. So we as a dental community are very creative with it. So we're going to see a lot of options come out. Just be certain that you're using trustworthy resources and that it's validated by some sort of testing. Where Dr. Causey came up with his device, he actually went to the hospital and said, will you do a fit test for me on this? And it passed the fit test.
Could you repeat once again the doffing sequence for PPEs?
Okay, I'm finished. The doffing system where I'm removing my PPE is that as I finish treating the patient, then I'm going to remove my gloves, sanitize my hands, remove my gown, remove my face shield, and then I exit the room and then remove my respirator and sanitize my hands.
Okay. What are your thoughts on an N95 respirator with a cool flow valve? Are they safe?
No, please do not buy those. That cool flow valve allows air that exits from your respiratory system to just flow out unfiltered from that valve. For those people who don't know, it's that one that you see that looks like the little round plastic dot on a respirator mask. So basically, if you're wearing that cool flow valve, you're just breathing your air right back out onto the patient. So no, not good. That compromises the protection for the patient.
What posters are needed to be displayed in the office as a requirement for OSHA and the CDC?
A poster in the front, it's recommended that a poster is in the front for patients that lets them know, if you do have any of these symptoms, please let us know. And so that, I'm trying to think, I would think that's the only one that's really recommended, if you would say, or required. Of course, you have to have the current OSHA poster on the wall. And in addition, I would recommend that you put the poster from NIOSH on how to properly do don a N95 respirator and how to do the seal check around it.
Some of these are partial questions, so I don't want to be adding to them here.
I think that maybe they were typing their question and then I answered it in the webinar before they even finished typing it. Yes.
We have a lot of thank yous here for people.
I treasure those thank yous because it is difficult times and it's a difficult topic to cover. And my goal has always been to inspire and uplift. And some of the news that I'm having to communicate is not inspiring or uplifting. So, but I think we can be our best. Together we can come up with answers and with technology and techniques that we can continue to provide safe patient care for patients and for the team.
Oh, here's a good one. Can the use of paper adhesive or surgical tape to help seal the borders of a level 3 mask be sufficient?
That would be what they refer to as an off-label use, not going by the manufacturer's instructions for use. It would be a compromise. I don't know how comfortable it would be. Some of you that are listening may have seen the Facebook video that they took a surgical mask and they tied a knot in it right next to the filtration and then tucked the excess on the inside and made it resemble sort of an N95, that it fit more closely around the face. I didn't have time to mention, but when I looked through on the slide that has all of the different levels of mask listed, the mask on the far side of it, the pink mask there, it actually has a metal strip. And I'm going to see if I can quickly go back to that slide that you can tighten underneath the chin. And that reduces the gap around the edge of that mask. Let me see if I can get up to the ASTMs on the mask, and I'll bring that up for all the viewers that are still looking. that we can talk about it. And oh, you know how it is when you're searching for something, it doesn't immediately pop up there. Trying to adapt a surgical mask is a challenge. And wow, we covered a lot of information in this
We certainly
webinar
did.
today.
We certainly did. But we're getting to the 2.5 hour mark here, so we're going to cut
Yeah,
this down in a
okay,
minute.
here's that slide. And I'll minimize my screen. If you can look on your screen now, you can see the assistant that she has the pleated surgical mask over her face. You always want to don a surgical mask with the white side towards your face, the pleats going in the downward area. And then do you see underneath her chin? There's a metal band there. This is called, referred to as an isolator mask. And when she pinches that, it tightens the gaps around the edge. So by closely fitting the metal band across the bridge of her nose and then shortening this after she's donned the mask, she gets a closer fitting and therefore reducing the air that can get in behind the mask. So that would provide a little bit of additional protection. It's not the equivalent of an N95. I want to be real clear on that. An N95 respirator mask provides complete protection against aerosols. But when you look at the big picture and with the PPE that we have available, and you add the face shield for it, there is a risk, but you've minimized your risk. I think that's the best way to phrase it. You do have a risk, but you've minimized your risk.
If an employee is COVID positive, do you feel written medical clearance from a physician is necessary before an individual comes back to work?
Not according to the guidance that we've been given. On the slide, they'll be able to see, 72 hours since having a fever without taking fever-reducing medicines such as aspirin or Tylenol, and then 7 days since the first symptoms. Now, as tests become more readily available, that guidance may change, but that's the current standard.
Now here's a different one. On the reuse of N95 masks, please address using microwave steam sterilization bags used to sterilize breastfeeding equipment for these masks. It is an option. I've seen microwaves, the steam sterilization bags, rice cookers, put them in a toaster oven at 150 degrees for 30 minutes. None of those are validated. And whenever you add moisture to an absorbent material, yes, you may have killed the SARS-CoV virus, but with that moisture in there and you take it out, take the mask out, now you still have the possibility that bacteria could get in there. So you could have mold and bacteria growing in those filtration layers of the mask. I really think that, using those off-label methods is a health hazard. Okay, here's our last question for today. Recommendations on face shields. How often would you change them, or should you wipe them clean?
I think you should wash them with soap and water. Just as you do your safety glasses in between. Washing them with soap and water is going to preserve the face shield. If you wipe them with a disinfectant, that disinfectant is going to scratch the face shield and leave residual disinfectant that can cloud the face shield on it. So decontamination would be washing it with soap and water. Being careful if you have one of the sponge tops at it that you don't get the sponge top wet with it.
Well, thank you, Jackie, for this practical and informative program. I know that everyone participating in this course will take this information back to their practice as they prepare to reopen for their patients. The main thing we can say is be safe, don't take chances, stay well, and everyone have a pleasant afternoon. Thank you.
Thank you, Dr. Boris, and thank the Chicago Dental Society for the opportunity.